Much. So this is the last bout of the day. I thought maybe I'll speak the toughest topic at the end. This has got a story to it. So this was like my nani, my maternal grandmother. She passed away at 78. She was diagnosed that time multiple myeloma, but was a borderline case. So we don't know whether it was multiple myeloma or not. After that came the expert view on ATTR, and now I retrospectively, when I look, I feel that maybe I was missing out on ATTR, basically trans thyroid, or maybe AL, but maybe I was missing out on amyloid cardiomyopathy. This was like 10 years back, but that's the perspective, and these are my disclaimers. So what I'm going to talk about is why it's an important. We had an oncologist on the supposed to have on the dais, but unfortunately he's not here. Because this is now cardiologist ની બધાની ટેવ હોય બધી બાજુ ઘૂસી જવાની જેમ ડાયાબિટોલોજી ઘૂસી ગયા હવે થોડું ઓન્કોલોજીમાં બી ઘૂસીએ છીએ અને these people Pfizer people tell me સાહેબ પહેલી વાર કરો છો મેં કીધું હવે છેલ્લી વાર નથી આ ઘણી વાર બીજી વાર કરશો. So this is one therapy that probably again we are entering into now our there is oncocardiology now, that's also coming up very strongly, where you have echo assessments, looking at the GLS in cardiac patients getting chemotherapy. There is a separate chapter on cardio-oncology where onco patients should get a thorough cardiac evaluation and also modify their therapy by the echo assessments. And that's why it's so important that before that you should miss out on a therapy like this for a patient who's got a cardiac disorder, which can be treated by a therapy which would give longevity. So I'll be talking about these various aspects, and then probably why shall we focus firstly why every echocardiographer should know about cardiac amyloid. So it's misdiagnosed, as probably, I don't know, 10 years back there was no concept of evaluating this. There were hardly few radionuclear centers, so there is very little knowledge, misconceptions, inefficient sensitivity, perceived rarity, associated tissue biopsy risk were involved. So amyloidosis is an infiltrative restrictive cardiomyopathy, which is basically either you have two types. One is light chain amyloid, another is transthyretin amyloid. The breakthrough that has happened is now the transthyretin amyloid can be treated with therapies like tafamidis and give longevity. If my maternal grandmother had taken this, maybe she would have been here for another 2 years before she died. So what is a transthyretin amyloid? Basically, it's mainly produced in liver and spore subunit, which is dissociate, and it then aggregates and forms what is a amyloid fibrin formation, which deposits in the heart and impairs its functionality. It can be either a wild type, which means the first way, or it can be a mutant type. So there are two types of it, and to make it simple rather than complex, its prevalence in patients with reduced ejection, preserved ejection fraction heart failure, it accounts to almost 1/7 or 1/5 of the patient. That is 7 to 13% of restrictive cardiomyopathy is this. And the mortality is because of the progressive heart failure, and survival after the diagnosis is 3 to 5 years in West. In our countries, it may be as little as 6 months. Median survival for hereditary is 26 to 62 months, and wild type it is 43 to 67 months from diagnosis. Now, it has a varied presentation. You have preserved ejection fraction patient who's come with either conduction block. So a lot of pacemakers that you're putting without, you think, echo ma LVEF che and a complete heart block che. And actually what you've missed out, you put a pacemaker and she dies of heart failure. What probably you missed out is a conduction abnormality in a patient of HFpEF because of amyloid. Also aortic stenosis, TAVI kari didu, AVR kar didu, and patient died. Why? Probably the patient had ATTR amyloid. So it's the finding the right lead and finding out who should get it. So this is very simple. I'm going to make warning signs very simple. Any heart failure in a patient who's more than 65, or aortic stenosis more than 65, or hypotension or normotensive in a patient who was previously hypertensive suddenly gets hypotension. A lot of times you have patients who have hypertension. તમે antihypertensive લેતા હતા dose અને 2 દિવસ પછી સાહેબ ચક્કર બહુ આવતા, BP is now low. Or you have, if you do imaging, etc., subendocardial or LGE on cardiac MR, or you have apical sparing with longitudinal strain on echocardiography, or there is decreased QRS to mass ratio, pseudo Q wave, also we call as pseudo-infarction pattern, or AV conduction block with LV thickness more than 12, and any one of this is good enough to make a suspicion. So once you have a patient with signs and symptoms of heart failure and an echo ma simple કે ECG માં લાગે MI introceptal થઈ ગયું છે અને echo જુઓ તો hypertrophied EF 65%. Very simple for an echocardiographer to suspect a cardiac amyloid. Speckled appearance is secondary, but if you see ECG showing MI, echo not showing MI, that's very strong suspicion of a patient of amyloid. So scintigraphy grade you have to look at. If the suspicion persists, you can do cardiac MR. So best way is આપણા ત્યાં શું કરી શકે? SPECT scan. Just do a radionuclear scan. Non-invasive, get a SPECT scan. And when you do SPECT scan, if there is scinti grade is more than 3 to 4, that means you are dealing with a cardiac amyloid. Which is if it's more than grade 2 or 3. એમાં simple હોય છે. Heart ની density SPECT માં bone ની density કરતા વધારે હોય, that means there is selective uptake. Technetium pyrophosphate scan, which is easily available all across Gujarat, and it can be done in a patient who is suspected for it. And you of course then can do a hematologic test, which can be AL amyloid mate, and then the diagnosis is different. So you have a patient which have multiple healthcare professionals have to play a role. You'll have neurologist who will pick up a patient from neuropathy, orthopedic from the standard protocol for testing biopsy tissues, hematologist, cardiologist, nuclear guy, gastro, genetic, primary care physician, healthcare professional. So basically what this therapy, tafamidis, does, જે ટેટ્રામર બને છે એને એ અનસ્ટેબલ કરી દે. So then it is easily circulating naturally through the bloodstream, and this free therapy, that tafamidis free acid, which is bioequivalent of 80 milligram tafamidis, is approved therapy now for ATTR cardiac amyloidosis. So it's the only approved treatment which is targeting TTR destabilization and prevents the progress and preserves the natural function of TTR. So tafamidis is the only therapy which is effectively treating ATTR amyloidosis, cardiac amyloidosis in randomized trial. So this is a trial called ATTR ACT trial, where they gave patients tafamidis 80 or 20 or placebo, and then they followed it up in the long term with the LTE, and they continued this, and they randomized to 2:1 for 80:20, and then they were, of course, once the outcomes were there, protocol amendment was done, and open label free acid 61 milligram QID was continued. What did it show? It showed that the survival was more in patients given tafamidis. 71% survival at 30 months compared to just 57% in those who were not given this therapy. So average, again, hospitalization also is only 0.3 versus 0.46. So what the ATTR CAD showed, that functional quality improves. She is able to walk 76 meters more. The quality life improves by 14 points. And the results also for NT-pro-BNP, which is a marker for heart failure with preserved ejection fraction, also improves significantly. 80 milligrams by 45%, and 20 is 23%. The placebo, when you just give therapy for preserved ejection fraction, like the dapagliflozin or the ARNI, which is the standard care, will be only 12%. So this is a therapy which is very safe. No safety concerns were identified in the study. Adverse events remain similar to the placebo, and this has been a follow-up of like 58 months, which is almost like 5 years. And the post-hoc analysis shows that the all-cause mortality by taking tafamidis versus those initiated on placebo has been now followed up even beyond 72 months. So the post-hoc analysis, 5-year all-cause mortality is reduced by 41%. So this is one therapy which has shown significant improvement in survival at 5 years, with 53% privilege survival tafamidis versus just 32 on placebo arm, and there is 44% relative risk reduction for all-cause mortality, and all-cause patients with ATCR with baseline functional class 3 at 60 months is reduced by 35%. Also, it's irrespective whether it's a wild type or a the mutant type, both the groups will work. So, or you don't need to be distinctive of બેમાંથી કયું ATTR-CM છે. Irrespective, you just diagnose ATTR-CM and you can do. So basically, transthyretin amyloid cardiomyopathy is misdiagnosed, underdiagnosed. It's an orphan disease. Orphan disease, એનું કોઈ નથી, કોઈ શોધતું નથી, કોઈ ટ્રીટ કરતું નથી, અને એલ્ડરલીમાં કોઈને પડી નથી. That's the problem. But then when I look at it from a personal story, I think if I had to pay whatever money it took, and if it was going to give 3, 4, 5 years more for my grandmother to live, I should have probably, if this therapy had been available, would have been greater. benefit to her. So it's demonstrated overall mortality and hospitalization rate compared to placebo. Patient quality and functional biomarkers improve. Post hoc analysis has demonstrated 5-year survival to be much better. With patients in continuous tafamidis cohort show greater improvement with baseline class 1 or 2 or compared to 3, and patients with continuous cohort have similar survival rate for both the genotypes, and it's a well-tolerated therapy. The monitoring, as I said, you need to look at the echo and the ECG, and once you have done it, the wall thickness will also improve, systolic function will improve, so would diastolic function, and no onset of anarrhythmia is what you need to monitor in elderly who are more likely to develop atrial fibrillation and AV block. Thank you very much for patient hearing for the talk on tafamidis. Thank you. So cost of the therapy, I think is 1.5 lakh rupees, 1.2 lakh rupees, and it is to be continued for lifelong. So 5 years, no, per shot for 1 month. So it's costly, but then it's worth it if you live. So that's why I say it's an orphan disease difficult to diagnose, disease difficult to treat, no support socially, emotionally, financially. There is no support system for it. But I think Pfizer is supporting in terms of getting the genetic profile done for free, and they also support for the follow-up assessment and nuclear scans in Gujarat. So if you have suspicion for a patient with amyloid, they get a spec done, and I think they waive off the charges if the patient, they pay the charges of diagnostics if the patient goes through the therapy. That way, I think there is some support structure emerging. It's reimbursable, I think, from Mediclaim point of view. So if you're hospitalizing, if the patient has Mediclaim, it can be covered. But then dar mahina 1.25 lakh ketla mahina reimbursement ni policy ketli જોઈએ will be a question. But I'm sure this will come into consideration because this is a problem of oncology. Oncology માં બી આ થઈ રહ્યું છે કે chemotherapies are evolving on outpatient. અને reimbursement issues are coming even in oncology. પેલા કે દાખલ થાઓ તો મેડિક્લેમ મળે. હવે ગોળી ખવડાવો તો મેડિક્લેમ ના મળે અને બધી ગોળીઓ થઈ ગઈ. You have CML, you want to treat, you give dafasitinib or timitinib or whatever, and patient doesn't have to get admitted. So then again there is an issue કે તમે ટેબ્લેટ reimburse તો again first આપણે જે બધા કરીએ જે એકવાર એડમિટ થાય, પ્રિસ્ક્રાઇબ કરે, 3 મહિના reimbursement થાય, ફોલો અપ માટે, ડાયગ્નોઝ માટે, marrow માટે દાખલ થાય, marrow વખતે ફરી ઇન્ડોર લખાય, ફરી prescribe થાય. So that keeps on happening. So maybe there must be some way of looking into the whole aspect. But I think there is 1 patient or 0 patient from Gujarat so far. Gujarat. Okay, so there are already 5 patients from Gujarat because when I was getting part of the program for the screening, I screened 5 patients. 5 માં એક AL આવ્યું, ATTR ના આવ્યું. એક માં 90 વર્ષના માજી હતા તો પેલાને સ્કેન જ નતું કરાવવું કે હવે માજીને શું કરવું, થઈ ગયું હવે સાહેબ જે હશે તે. એક patient already was on thalidomide and all that, and that she was doing better. Thalidomide is given for amyloid kidney, so she was doing good. So સગા oncologist said કે કઈ જરૂર નથી, હવે સારું તો છે, 5 વર્ષ તો થઈ ગયા thalidomide પર, ચાલુ રાખો. So that patient was lost. So I have not initiated on any patient, honestly speaking, but I have screened 5 patients. 2 were negative for the scan, so did not turn out. But I'm glad to hear that 5 patients are there already on tafamidis in Gujarat, and I think Mumbai has probably the largest number of. Bangalore has highest number. They have a good cardio oncology team which looks into the whole aspect, and that's where the whole therapy is initiated. So thank you very much, and we can have the second aspect of the talk from Dr. Raj.
Amal, thank you.
Yeah, good evening, everyone. It's a wonderful feast of knowledge today. Thanks to Kamal Sharma and whole team. We have 3 cheers for them from all audience. Well, I am a critical care specialist, and I was called because I am dealing more with the hospice therapy routinely. So he told me that just discuss about the hospice therapy. And as a critical care specialist, I am very optimum. But since my job is to counter him, so I try my best to counter him. So basically in ATTR CM, like in cardiomyopathy with amyloidosis, the commonest is diastolic heart failure. And what we discuss is this: the cost effectiveness of tafamidis therapy So this is the interesting studies. I think this is the biggest study available. So the cost of therapy is $225,000 per month in US, and they did studies that they found that with the quality adjusted life year gained, that is 1.79, and the cost is rising to $880,000 per month, and they found that the ratio with the cost effectiveness is 0% in 10,000 probabilistic simulations. So there has to be a 92.6% reduction is required in cost. There are so many arguments in US with a Medicare, and even with the reduction, they come with a $2,000 per month. That is also quite high. So with that, the quality assured life, the lifespan increases 1.29 or 1.5 times. So that is hardly 13 months. And that is also with this Tapamid is not a magic pill. The patient has so many comorbidities. So all other medicine, all other therapy, all other hospitalization, all other complications is getting added. So we really have to think before prescribing this medicine. So this is from a physician that it is anxiety provoking. If nobody believes that comes to my clinic where I have to sit with patients who are worried how they are going to get it. So you have to sit with and visit, because patient is already sick and you are talking with the financial aspects and about disease. It is really very, very anxiety provoking. And most of the patients are old age, right? This disease is of old age. So to spend $250,000 every year on patients who are 80 years of age. So not to be disrespectful to them, but it is not sustainable. See. So this is, I think, the available in Indian market at 1,20,000 rupees. So what I feel is this is the famous story like Birbal ni khichdi. You feel like that, oh, it is too far. It's too far. So then I believe that we have to focus more on hospice therapy, because that is more rational, more optimum, and we need to focus on that. I think maybe we are missing the current Indian data, but with a good hospice therapy, at least you can sustain for a longer time. So we know that diastolic heart failure is with a normal left ventricular systolic function in absence of cardiac valvular disease. The syndrome of heart failure is DHF. Now these are the most common conditions, three conditions: the presence of signs and symptoms of heart failure with a normal ejection fraction, and presence of increased diastolic pressure or impaired filling caused by delayed isovolumic relaxation or elevated stiffness. The pathophysiology, all we know that there is a ventricle, there's a thick wall with a small cavity. So there is an increased left ventricular mass versus volume ratio. When the left ventricular becomes stiff, it relaxes slowly in early diastole. So eventually, there is a resistance in a filling pressure in the late diastole. So your diastolic pressure got elevated. Now these are the typical diagnostic criteria. I am just focusing on that. The axial dyspnea, orthopnea, gallop sounds, lung crepitations, and pulmoedema with a normal or mildly reduced ventricular systolic function, and evidence of abnormal left ventricular relaxation, filling, diastolic distensibility, and diastolic stiffness. Now there are 4 treatment goals that has been advocated: the reduction of central blood volume by means of diuretics, improvement of LV relaxation by means of calcium channel blocker or AC inhibitors, regression of LV hypertrophy by means of AC inhibitors and ARB that we use commonly since years, maintenance of arterial contraction and control of heart rate by means of beta blocker and antiarrhythmics. So this is a treatment algorithms for confirmed ATTR amyloidosis. Heart failure, we know that we are treating with all this stuff. This is modified agents that already Kamal has discussed. The Tafamidis is a approved drug. Another drug for cardiomyopathy and neuropathy, that is inotersen and patisiran, that is even cost is double than tafamidis. It is still coming, so it is the cost is double than tafamidis. And for arrhythmias, you can give beta blockers, you can give antiarrhythmics, you can give NOACs, you can give warfarin antagonist, all this medical therapy. And for the device with a heart block, you can have a permanent pacemaker, ICD and CRT in some patients. Practical points in ATTR-CM, that the goal-directed medical therapy is very, very poorly tolerated. All these drugs, as Kamal has told, that they can produce hypotension. Beta blocker may worsen heart failure symptoms. The benefit of ICD has not been studied very well in randomized controlled trial. This is modified therapy, which is already we have discussed and which is under a great discussion, like TTR silencers, TTR stabilizers, and TTR disruptors. As we have discussed, the inotersans and patisirans, they are very, very costly drugs that will not improve the disease. It just slowing the progress. It is just slowing the progress. Now we discuss about the hospice therapy. When we have to consider the hospice therapy, so out of these criteria, 1 and 2 must be present, and 3 may be in a supportive. So patient is already optimally treated with diuretics and vasodilators, which may include ACE inhibitors or combination of hydrolyzin and nitrates. If patient has hypokalemia, so you can try only with the nitrates or hydrolyzin. So that has to be documented on medical records. Patient having angina at rest, and that is resistant to standard nitrate therapy, or patient is not a candidate for invasive procedures. Patient has significant symptoms of recurrent congestive heart failure at rest, and it is classified by NYHA class 4. So unable to carry any physical activity without symptoms. Symptoms are present even at rest, or if any physical activity is undertaken, symptoms are increased. And third criteria is there is a resistance SPT or VT, history of cardiac arrest, history of unexplained syncope, embolic phenomena, concomitant HIV disease, or ejection fraction is decreasing. Now these are the treatment guidelines, like you have to address the aortic stenosis, thromboembolism we have discussed, conduction disorders, heart failures, atrial fibrillation, and ventricular arrhythmias. And these are the supportive measures. So there is a great modality of treatment is available in a hospice. If we keep tafamidis and the hi-fi drugs aside. And these are the supportive measures that we are commonly using, like sildenafil, like neprisilin inhibitors that is available, ivabradine, iron supplements, renalizine, mitochondrial enhancements, statins, serelaxin, that is endothelial redox balance restoration. Paraesthesia, that is not available, but these are the supportive measures which are available. So what I mean to say is, whenever you are addressing the disease, you have to address it as a whole, not like one drug which is a magic bullet and it will you give and it works like a patient becomes Superman. So it's not like that. So hospice therapy, I think we have to be more rational and more optimal. Thank you very much.